Hello, everyone. Welcome to this week's edition of It's Worth a Shot, hosted by Mountain Pacific Quality Improvement. We are just about ready to start. I see a few folks that are jumping in from the waiting room. Today is May 31st, the last day of May. Can't believe it. So I hope everyone is well. Thanks again for joining us. On today's Worth a Shot, we will be discussing culturally and linguistically available services, as well as the importance of medication reconciliation. All right, next slide, please. A few reminders and updates for this week. I just wanted to make sure everyone knows that there are still COVID-19 therapeutics available. So your Paxlovid, your molnupiravir, and your remdesivir are still available outpatient COVID-19 therapeutics. Those the monoclonal antibodies, those are no longer authorized, and really because they're just no longer effective against the Omicron variants. There is Veklury is still available. It is given IV over 3 days, and really most pharmacies still have Paxlovid and molnupiravir in stock. So just reach out to your primary pharmacies, have that conversation. If there's an opportunity or a candidate within your resident population that may be eligible for therapeutics, again, those are still available. And then also just a public service announcement, you can prescribe and obtain those for a patient from a pharmacy through the normal prescription processes. So there's no additional hoops or additional paperwork that you have to fill out at this time. So just a reminder, COVID-19 therapeutics are still available. I know we do have some regions and outbreaks, so sharing that forward. Next slide, please. As always, feel free to add your webinar topics and clinician ideas into chat. And we always put in that post-presentation evaluation into the chat box towards the end and throughout our presentation. And there's an opportunity when you complete that evaluation to also enter in topic ideas. And I do look at those every week and pull from there to help build our calendar out. So thank you all for participating and completing those evaluations. And we will continue to meet every Wednesday. And polling question for today. Does your medical director help provide education on immunizations for your staff and residents? Yes, no, or other? And if you enter other, I'd love to hear from you. See if we can get a couple more responses and then we'll close that polling question out. Again, does your medical director help provide education on immunizations for your staff and residents? Like the majority say no. All right. Well, thank you guys as always. There we go. Now it closed. Next slide, please. A quick snapshot of our COVID-19 hospitalizations, deaths, and emergency visits by geographic area. Great news on the home front. Last reporting period ending May 23rd, we continue to see a decline in hospitalizations across the United States, decline in deaths, and we're holding steady at about 17% of the population receiving the updated booster dose. So again, positive news. Next slide, please. As we look at the COVID-19 hospital admission levels, lots of green, which is a good thing. And just a reminder that individual level prevention steps can be taken based on your COVID-19 hospital admission levels, low, medium, and high. Really all COVID-19 precautionary steps include reminders to stay up to date on your vaccines, maintain ventilation improvements, avoid contact with people who have suspected or confirmed COVID-19, follow recommendations for isolation, and follow recommendations to do if you're what to do if you're exposed, and reach out and visit with your healthcare provider and your local resources. So again, lots of green. That's great news. We want to see that. Next slide, please. Last week's questions and answers. We had a few folks reach out, really seeking clarification on what vaccines should healthcare workers receive. And some of you may have seen an email I sent out. There's a link that the CDC has where they list out, and I will drop that in chat right now for you guys. They list out healthcare, what vaccines healthcare workers should have. And they include COVID-19 among that list now, chickenpox, flu vaccine, Hep B, meningococcal vaccine, MMR, and Tdap vaccines. Those are all recommended vaccinations for healthcare workers. When you look at each individual state, be mindful that some states do have legislation that defines what vaccines healthcare workers need. If you live in Hawaii, we have a message out to the immunization unit there to define that. And we also have some messages out to our other partners. So if you are interested in some further information, please reach out to me. And once I hear back from those folks, I'll be sure to share forward as well. So thanks for those couple folks that reached out and asked this question. It was a good one. Next slide, please. So with that, our first speaker is Jamie. She's our project assistant with our Mountain Pacific team, and she will be speaking to us about culturally and linguistically available services, the how and why it's important to implement in your facilities. Jamie.
Hi, everybody. I'm Jamie Keene. Like Jesse said, I am a project assistant with Mountain Pacific. And Mary, if you want to hop to the next slide, we can go over the class. So culturally linguistic available services to make your life easier class. We took the national standards checklist of how to implement this, and we summarized it, because if anyone is familiar with the national one, it is 15 steps, and it's kind of overbearing when you're just trying to figure out if this is something that needs to be done in your facility. So what it does, it's going to help you provide effective, equitable, understandable, respectful, quality care and services that are responsive to diverse cultural, health beliefs, practices, preferred languages, health literacy, and other communication needs. So this will also cover your deaf people who are needing sign language, people who are having speech impediments or speech problems. This is going to help incorporate their needs into your facility. Next slide. So again, why it's important. One study has shown that people who are more involved in their care tend to be more satisfied. They're more likely to understand their acute and chronic conditions. They're more able to make informed decisions that can better help them. So as they're being able to make these informed decisions, we are able to incorporate their needs. Next slide, Mary. And then why is it important and how does it affect your facility? I found some FTAGs that are highly important in the residents' rights. If your resident is not able to understand not only the verbiage used in their care plans, but the language, they are not able to help make these informed decisions in their own care. They're not able to participate in their care planning. They're not getting the correct forms of communication. And F603, free of involuntary seclusion, those that have a language barrier or a culture barrier, how secluded are those people going to be? So fixing that will help bring them into the fold of your facility. And next slide, Mary. So how can you do this? First off, complete an assessment. Use our checklist to go through and find out what cultures, what languages you're seeing prevalent in your area. Find out what community partners you can merge with. See what they can help bring in. I know a few nursing homes that take some of the residents to powwows, or they will bring some of the people into their facilities for some of these events. Bringing in more ethnic foods, more multicultural holidays. It could even be as simple as bringing in some of the hobbies that the residents did prior to coming to your facility, more woodworking for areas that were in logging, more gardens for your farming and ranching people. Pair with your shelters or your veterinarians to include your ranchers. Just simple things like that can really help make a difference in your residents and their quality of life. And with the push for health equality right now, this is going to be your best way to start that process. So the next slide is some resources. This will not only give you more information on what this is, but it's also going to help give you start points and explain the why a little bit better too. Do you have any questions for me?
Thanks, Jamie. That's a great introduction. And I think it really gets us thinking about maybe it's time for us to look at this topic a little bit closer in our facilities. And I just dropped all those resources in the chat box. So feel free to reach out to us if you have any questions. Reach out to your local account manager with Mount Pacific. And if we can help support some learning opportunities in your facility, please let us know. Thank you, Jamie.
Thank you.
All right, next slide, please. So next up, our very own Jennifer Miranda. She is a pharmacist and case management supervisor for Mount Pacific, and she is going to be visiting with us today about the importance of medication reconciliation.
Hey, yeah, thank you for that introduction. I'm excited to be here today. I did MedRex at an ambulatory care clinic for 15 years, and I'm excited to maybe share some of what I learned today. A lot of it you probably know, but I want to touch on the high points. So thank you for having me. So yeah, medication reconciliations are definitely a critical need in decreasing hospital readmissions and in decreasing adverse drug events. So there's a few things that we can touch on that may be enough to hopefully keep someone out of the hospital. So medication reconciliation is a HEDIS measure, so the healthcare effectiveness data and information safety measure. It's also a STAR measure, and that's why it's so important as a facility to do, because it does increase the STAR rating and overall improves patient health. So a medication reconciliation post-discharge is, of course, when medications on discharge are reconciled with what the patient was taking prior to being admitted to the hospital. That is a little bit easier when they're going from the nursing home to the hospital and back, although it can still prove to be very difficult. I think it's even harder when they're coming directly from home to the nursing home because we can't always trust what they're telling us they were taking. So for it to be counted as a STAR measure and get credit for it, you do have to make sure that you document in the outpatient record, include the date that the medication record reconciliation was done. It must be performed by an RN, a PA, a nurse practitioner, a physician, a certified nurse midwife, or a clinical nurse specialist. That person can do it, but the overall medication reconciliation does have to be signed off on by the doctor that that was done. And you do have 31 days total to do it. You have up to 30 days post-hospital discharge, and the day of discharge is part of that. That's where the 31 days total comes from. For billing codes, I know there's a lot of bundled billing, but the primary billing codes associated with this are for transitional care management service codes are the initial direct contact with the patient or the caregiver, either by phone or electronically, by a clinical staff member that was appointed by the physician or provider, has to happen within 2 business days of discharge. And the day of discharge does not count, which is nice because sometimes they don't get out until 4 or 5 at night. So the 2 codes that I see the most are 99495 and 496. The difference is 495 is a patient with moderate medical complexity and was seen by the provider face-to-face within 14 days of the hospital discharge. And 496 is a higher level of service and you get a better reimbursement. That's for patients with high medical complexity seen by the provider face-to-face within 7 days. Medication reconciliations in order to count must be complete no later than the date of face-to-face provider visit, which makes sense. A non-reimbursable current procedural terminology category, or CPT code, is 1111F. And that means that the patient doesn't have to be seen by the provider. Like, we know the doctors are really busy. Maybe they don't have time to get down and see the patient at the nursing home. But as long as the medication reconciliation has been done and the other items have been met, it can be noted that the medication reconciliation was at least completed, and you can get credit for that by using the 1111F code. So the one thing is that time sensitivity does equal improved outcomes. That's why you get a higher level of reimbursement within 7 days. But there are data that show medication reconciliations, even performed within the first 3 to 7 days, really do decrease readmissions and contribute to cost savings by reducing adverse drug events. Transitions of care medication reconciliation, I mentioned how that can take place, but the purpose of that is to compare a new medication order to the medications patient was taking prior to readmission to the nursing home, like we talked. And again, the overall goal is not only the adverse drug events that we're all aware of, but also to decrease death, because that indeed can happen from an adverse drug event. I also wanted to just briefly touch on a slide that this is actual real data from Alaska, Hawaii, Montana, and Wyoming from internal data collection at Mountain Pacific. And it just shows the primary adverse drug events that we noticed in 2022. And as you can see there, what we found was anti-diabetic associated adverse drug events, anticoagulant associated adverse drug events, and opioid associated adverse drug events were the highest prevalence within these facilities. So something to be extra cautious of if you see somebody coming back to you on any of those agents, something to tuck away in the back of your head, as those tend to be the ones nationally even that are associated with high risks. The 3-step process for medication reconciliation is to verify, not only comparing the med list, like I mentioned, but also looking at the names of the medications, were they entered correctly? And the times, does that make sense that if he needs to go to sleep, it's being prescribed in the morning? Probably not. And the dose, does that dose fit what that person was or was not on prior to readmission to your facility? Clarify, is the medication and the dose appropriate? And reconcile or match up the medication information. So document each change, whether was something omitted, should something have been started or stopped. For example, a lot of people will have their diuretics held while in the hospital, or even aspirin held in case they're going to surgery. The diuretics are often held because of a decline in kidney function, and they want to get that better and get them rehydrated. And then they just fall off the list and they're not resumed upon hospital discharge. They're not written for. So checking for omissions, checking to make sense of the dose. So if they do have high blood pressure and you notice that they came back on half the dose of lisinopril they were on, does that make sense? Or do you see like a note that was sent with the discharge summary that says that they had a hypotensive event and that's why it was low? I know we don't always get the discharge summary, very rarely is it all there when we want it, but just any information you have, try to be like a detective and put it together. I know that takes time though. And then look for additions as well. Unintended discrepancies. So medications or treatment plans not explained by the resources and comment you can get from the patient's clinic, or their condition that they tell you about, or their medication list. So a tool is to look for the diagnosis codes. Like that's a big part of the investigation. Does the medication list match up to the diagnosis code? Is there a diagnosis not being treated that should be? Is there a medication listed that you do not see a corresponding diagnosis code for? That could be an indication that, yes, we probably forgot to add something that we should. Some examples of making sure that the medication list was accurate would be look-alike, sound-alike names to remember. They may have been entered wrong in error. So metformin versus metronidazole, and when you're in Epic and you're typing in a word and you click met, you can select the wrong one. One is, as you know, a diabetes medication versus an antifungal. So that can be a big deal. And then, oh, so sorry, Mary, that I didn't tell you to advance slide. Diabetes medications. Oh, sorry, metformin was a diabetes medication. And the danger with that, getting the wrong one, would be that metformin can cause hypoglycemia, you know, so that's important. Also looking at clonidine versus clonazepam. Clonidine can be used for hypertension and night terrors versus clonazepam is a sedative hypnotic. If someone has clonazepam on their med list, it should not be attached to a diagnosis code of hypertension, or that would be a red flag for an error. Another thing to look out for is a deep vein thrombosis and them being sent out with no anticoagulation. I've seen that. Another one is Entresto, but no heart failure diagnosis. Like that's important to know. Did they just get newly diagnosed with heart failure? Because then you're going to be wanting to look at input and output and measure for edema and all of those things. So just going the extra step. And still on that slide, omissions, look for if they were on a statin prior to admit and now they're not. Like I mentioned, the statin can be a big deal because a lot of elderly people, it's held because of liver dysfunction. And then again, when they get out and their liver's better, it's not resumed. Duplications, look for that. Warfarin Xarelto would be a duplication. Bumetanide and furosemide are in the same family. Metoprolol and atenolol are in the same family. Types of things like that. Two medications within the same class. Next slide, please. For dosing, watch for errors with the dosing. An example would be with furosemide and potassium, those usually go hand in hand. If you see them just come back with furosemide and no potassium, or just potassium and no furosemide, that might be something you want to clarify. Some questions to ask is the dose the patient was previously taking the same or different? And the biggest follow-up question is, does the dose make sense? If the dose was decreased, do you understand the reason? and does the reason make sense? Also for follow-up, that's important as the days go by. And again, the example of the furosemide and potassium would be if it had a counterpart, was its dose also decreased? So if the furosemide dose was cut in half, was the potassium dose cut in half? A lot, by half as well. I usually don't see that happening. And the D's that I like to remember to monitor for include drug-drug interactions, such as, sorry, next slide. I'm horrible at that. So sorry, Mary. Warfarin and sulfa, digoxin and verapamil. Drug disease state interactions would be diphenhydramine with glaucoma, especially narrow angle glaucoma that can cause blindness. Anti-inflammatories with kidney disease, that can increase the creatinine. And duplications, watching for generic versus brand name, amiodarone and pacerone. I actually had a patient that did that, didn't know they were the same thing because they were different names, that ended up in the ICU with amiodarone toxicity and almost passed away. So just things to think about. Next slide, please. And then for lab monitoring, I would always ask, were the appropriate lab codes ordered upon discharge from the hospital to correspond with the new diagnosis, medication, or changes in medications? So if you see anemia, was a complete blood count reordered and an iron panel reordered for follow-up? Warfarin was an INR ordered for follow-up, and then a diuretic with potassium. Did they order a comp or a basic metabolic panel so that we can look at that creatinine and the potassium level? Next slide, please. And lastly, I'll just leave you with some considerations. Is there a need for additional support with this work? And if so, how could your team best be supported for that? I know personally time is the biggest thing that we could all use for additional support, but if you think of any other things, just reach out to us and we'll see if that's anything that we can brainstorm for with you. So that's all I have today. There are some references that will be shown there, and you'll have access to those as well. So any questions for me today?
Thank you, Jennifer. I'm just looking through chat and I don't see anything yet, but I did drop your resource links into the chat box. So feel free to grab those out of there. A lot of great information, very important topic. Kyla, yes, I echo that. There's so much room for improvement. And if we can help support and align some education for your facility, maybe as you identify you have a higher prevalence of adverse drug events occurring, please let us know. We're here to help you, and we have a great team of subject matter experts. So Jennifer, thank you so much for presenting. We appreciate it.
Yeah, absolutely. Happy to help.
Any questions? Just some more things to keep an eye on, right, everybody? Well, we did just pop in a link for the post-evaluation. If you have a few minutes or moments, more like, we always appreciate feedback through completion of that survey. If you think of anything, please reach out. Otherwise, we'll give you back a minute of your time. Thank you always. Thank you to our speakers today. Stay well, same time, same place next week. Take care, everybody. Thank you.
Thanks. Bye.